This is message for all the participants. We're just waiting for people to join in slowly. I can see people still joining in. Sorry for the slight delay. There's been some technical issue. We are okay now. We'll start in about 1 more minute. We'll give 1 more minute and we'll start.
Actually, permission ಕೇಳ್ತಾ ಇತ್ತು ಸರ್. ಪರ್ಮಿಷನ್ ಕೇಳ್ತಾ ಇತ್ತು ಮ್ಯಾಕ್ ಝೂಮ್ಗೆ ಕ್ರೋಮ್ ಗ್ರಾಂಟ್ ಮಾಡೋದು ಸರ್. ಅದು ಬರ್ತಿದ್ದಿಲ್ಲ ಅವಾಗಿಂದ ಗ್ರಾಂಟ್ ಆಗ್ಲಿಂದ ಒತ್ತಿದ್ರೆ ಬರ್ತಿದ್ದಿಲ್ಲ.
Okay, it's 7:40 now. We're going to start. Good evening, everyone. Welcome to the next session on this Telearogya webinar series. We have an interesting session today. This is with regards to the most important in our psychiatry, which is regarding the adherence or the compliance issue that we come across on a regular basis. And today we have two eminent speakers and they have done quite a lot of work. They got enormous clinical experience, very vast wealth of knowledge they have. They can bring with their clinical experience and share with us how they do in their clinics, and it's an opportunity for us, to youngsters like us, to learn from them. And we also do have a moderator, young and dynamic Dr. Nayan Mutalik, who is a faculty and traveled all over the world. And let me introduce Dr. Mutalik. Before that, I request you all, this is one of those webinars where you can only view us, and Dr. Mutalik, if he's made co-host, he can give opportunity for you to speak also if time permits. And also, can you post all your questions in the Q&A box with your name and place next to the question, so that it is taken up by Dr. Mutalik. Let me introduce Dr. Mutalik. He has done his MBBS from JNMC Belgaum, and then MD from NIMHANS. He has had several international travel awards for young scientists by the DST. He attended Madrid in the World Congress of Psychiatry, and then he had WFS BP Educational Travel Award at 12th World Congress on Biological Psychiatry at Athens. He's awarded academic excellence by BVV Sangha's chairman and MLA Sri Dr. Veerana Charantimat in 2016 at Bagalkot. He's a Young Investigator Award in 13th World Congress at Biological Psychiatry. Is again one more young scientist at ICMR at Denmark. Young Fellowship Award at World Congress of Psychiatry. And he's had several publications, 25 publications, and he has done several workshops. He's current honorary treasurer of the Indian Psychiatric Society Karnataka chapter. He's currently associate professor of psychiatry at SN Medical College at Bagalkot. We do have the privilege of having a eminent panelist, all from North Karnataka, and they'll enlighten us with regards to this very important topic in psychiatry. With us, supporting us, is Mr. Ganeshan. Once again, I welcome you, sir, and I welcome all of you, all the panelists and participants. I hope you enjoy it. Have a great evening. Over to Dr. Mutalik.
Thank you very much, Dr. Vijay Harbishattu, sir. At the outset, I would like to thank the Telearogya team for giving me this opportunity for being the moderator for today's program on adherence therapy. And I take this as a privilege to introduce our today's speakers, so who do not need any kind of introduction, who are well-known, eminent, senior-most psychiatrists of Karnataka. Our first speaker, Dr. V. M. Mali Patil, sir has completed his MBBS from WIMS Bellary, and he completed DPM at NIMHANS Bangalore. He worked as a senior specialist in psychiatry and as RMO in a district hospital Raichur, now RIMS Teaching Hospital, and later he worked as district family planning officer at Raichur. He served as honorary secretary IMA Raichur for 3 terms from 98 to 99, 99 to 2000, and 2003 to 2004. He was a president IMA Raichur in 2004 to 5 and 2011 to 12. He served as state president of Indian Psychiatric Society, Karnataka State Branch in 2005 to 2006. He hosted CANSIPS 2006 at Raichuru in association with IMA Raichur successfully. He is the founder, president of Kalyan Karnataka Psychiatric Guild, KKPG, and he has won many awards. State government award for achieving highest number of tubectomy operations in Raichur district, and Vaidya Vibhushana award for meritorious services to the society and organization from KGMOA, and senior psychiatrist award by IPS KC at Mysuru in 2011, and Mahanta Shri award in 2012. I heartily welcome you, sir.
Thank you, sir.
And our another speaker, Dr. Anand Pandurangi, is a household name in north part of Karnataka, and not only for his clinical prowess in psychiatry and community-based therapeutic approach, but also for his philanthropic activities in the community. He has been practicing in a Michigan at his clinic in a Michigan compound, Dharwad. He has his graduation in medicine from Karnataka Medical College, Hubli, and postgraduate honors from Karnataka University, Dharwad, acquiring his clinical skills training from erstwhile Karnataka Institute of Mental Health, Dharwad. He has received many awards, and to name a few, a honorary doctorate by Karnataka University, Dharwad in 2018, Dr. Katila Pupai Manasa Trust Award 2017, and Distinguished Psychiatrist Award by Kedabums Bangalore in 2011, and Dr. B.C. Roy Honor Doctor's Day Award by Government of Karnataka in 2010, and Eminent Psychiatrist Award by IPSKC at CANSIPS 2010 at Dharwad, Bendre Award from Government of Karnataka, and Suvarna Karnataka Rajyotsav Award by Government of Karnataka in 2005. I heartily welcome you all, sir, for this talk on adherence therapy. Without much delay, we will start the session. Over to the first speaker, Dr. V.A. Mali Patil, sir. Thank you very much.
Good evening to all. Am I audible, sir?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Today, at the outset, I want to thank the Tele Arogya team, especially Vijay Harbisetter and Mahesh Kumar and Jagdish for giving us this opportunity. And also I thank our moderator who has introduced me so nicely. And I also welcome all the viewers, my friends, for this webinar. So today, my topic will be on adherence to long-term treatment or therapy. And my presentation flows as follows. Introduction, magnitude of the problem of poor adherence, definition of the adherence, implications of non-adherence, types of non-adherence, factors affecting adherence, how do we measure adherence, and what is my experience in Raichur. So this is how my presentation will flow. At the outset, the ultimate aim of any prescriber with prescribed medication therapy is to achieve certain desired outcomes in the patients concerned, because these desired outcomes are part and parcel of the management of any disease or disorder. Despite our best intentions and efforts of the doctors, those outcomes may not be able to achieve if the patients are non-compliant or non-adherent. This may result in serious detrimental effect from the perspective of the illness management. The therapeutic compliance not only includes patients' compliance with the medication, but also with diet, exercise, or lifestyle changes, distancing from bad habits as required in the therapy. magnitude of the problem is very vast. In general, it was estimated by some review studies that compliance or adherence rate of long-term medication was between 40 to 50%, and for short-term medication, it is up to 80%.
Mani Patil sir,
Yes,
one
sir.
ನಿಮಿಷ sir. Can you make it full screen sir? ನಿಮ್ಮ ಪ್ರೆಸೆಂಟೇಷನ್ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಅಂತ ಒಂದು ಮೋಡ್ ಇದೆ, ಅದೊಂದು ಹಾಕೊಂಬಿಡಿ ಸರ್.
ಬರ್ತಾ ಇದೆ.
ಇದು ಪ್ಯಾನಲ್ ಫೋಟೋಸ್ ಬರ್ತಾ ಇದೆಲ್ಲ,
ಕೆಳಗಡೆ ಸರ್ ರೈಟ್ ಸೈಡ್ ಬಾಟಮ್ ಅಲ್ಲಿ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಇರುತ್ತೆ ನೋಡಿ ಸರ್, ಅದೊಂದು.
okay.
Right. Thank you sir.
So for short-term medication treatment, it is around 80 to 80% up to. Compliance for the lifestyle changes are only 20 to 30%, and psychiatric patients exhibit a higher degree of non-compliance behavior than any other medical problems. In the developed countries, adherence to long-term therapies in general population is around 50%, but it is very much lower in the developing countries like India. Poor and sick are disproportionately affected because illness blunts their activity, creativity, and cuts out the opportunity. Unless consequences of illnesses are prevented or at least minimized, illness undermines the people and leads them to suffering, despair, and poverty. Poor adherence compounds and worsens the challenges of improving health in poor population and results in waste and underutilization of already limited treatment resources. So before we could come to the implications, we should know the clear definition of the adherence. The Oxford Dictionary defines compliance as practice of obeying rules and requests made by the people in the authority, and adherence as steady devotion or attachment or adherence to the rules. This is literate meaning. And in healthcare, the extent to which the patient's behavior coincides with the agreed recommendations of a healthcare provider for health and medical advice in terms of taking medication, following dietary instructions, or executing lifestyle changes. So this is the definition in the healthcare system. Any incongruence between health seekers' behavior and recommendations of the caregivers is considered as poor or non-adherence with the therapy. So there are types. How many types are there? See, there are so many types of non-adherence, like receiving prescriptions but not filling it. People come for consultation, they get the prescription, but they will straight away go home refusing because of some of the reasons for their own. And some people may take incomplete doses. That is, if you write for a month's prescription, they will take around a 1 week prescription or a fortnight prescription and discontinue after asymptomatic. And some people may take medications in the wrong time and increasing or decreasing the frequency of dose. Suppose if you give the BD dose, they will skip the daytime dose and they will start only night dose like this. Stopping treatment too early. For example, if we don't give them education regarding slowness of the drug effects and slowness of the improvement, at least 10 to 15 days time, they will stop treatment by 3-4 days because they want early improvement. So they may start too early. Stop. Delay in seeking healthcare itself is a non-adherence. They may nowadays, though it is very less, people go for traditional healing, traditional mantrikas, and then later on they come up to the psychiatrist. So that is the delay in seeking healthcare, which amounts to non-adherence also. Non-participation in clinic visit. Some attendants will come to the clinic and say, my son or whatever he is not ready to come to the clinic, but please give prescription. So that we don't usually entertain such things, and that is another part of the non-adherence. Failure to follow doctor's instructions, because if you say they take at least minimum 15 days to get the result, they may stop in between, or they may take incomplete dose, Okay, and they may not stop smoking or alcohol, whatever we do instruct to them in the interest of the patients. And they may have some drug holidays. Drug holidays means they will stop medication in between for a few days and start again on themselves. White coat compliance is they will have compliance only during the visits or just before the visits to a doctor. These are the types of poor or non-adherence. So now we'll have to look into the implications. Non-adherence could have a major effect on the treatment outcome and direct clinical consequences, especially in chronic illnesses and disorders. For example, hypertension, if it is not treated or if medicines are not, patients are not adherent to regular medication, they may go in for stroke or myocardial infarction. Infective diseases may have drug-resistant microorganisms. Depression may end in suicide. Psychosis, acute psychosis may end in chronicity. So these are immediate implications. Non-compliance could also cause increased financial burden to the society in the form of increased urgent care. Because they stop in between, they will have to come back again in the odd hours and they will get admitted. And number of hospitalizations will be more and treatment cost will also be more. So indirect implications are loss of productivity because of illness and negative effect on the patient's quality of the life. And another thing is if doctor did not detect the adherence or if the patient never report that they are not adherent to the treatment, there are chances that doctors may change treatment regimen frequently, which results in increasing cost and complexity of the treatment. So these are the implications of non-adherence. So now we'll go to the factors which results in poor adherence or non-compliance. These are the 5 review studies. So many, around 105 review studies have been done in various countries, and they have categorized the factors into 5: patient-centered factors, disease factors, healthcare system factors, social and economic factors, and therapy-related factors. These are interrelated and they interact. So that is why we will have to deal with all the 5 at a time, one by one. So now if we take one by one, patient-centered factors. See, demographic factors like age, ethnicity, and gender, education, and marriage status, as we found here with our experience, that doesn't have any much importance because age, though there are in the elderly people, some people will have more adherence capacity and others who have probably disabilities, including cognitive disability in the older age group, they may have poor adherence. So likewise, gender also, education also. Many educated people, they do adhere, and I have seen both. And many of them educated, they will have other priorities and they will forget to continue medication. So marriage status, sometimes it has a positive adherence effect if there is a good support from the spouse, otherwise it is reversal. Psychosocial factors like belief, patients' belief on the treatment. Many of the patients nowadays, though it is reduced, still the stigma is there and they think it is curse of some god, then wrong beliefs are there. In that case, adherence is very poor because many people talk about these things and they will divert their attention to other non-traditional healers. And another belief is that they should believe the doctor. If once they come to the doctor, they have to believe the doctor and that it is a disorder and he is able to give some result. If we continue medication as per his instructions. If they believe like this, they will get motivated, and attitude towards treatment adherence will be better. And because of some psychosocial stressors also, the adherence is very poor. And patient-prescriber relationship, that is doctor-patient relationship, is very, very important, because the way, the attitude and the behavior of the doctor and the are very important. I will come to the during next slide. Patient's inadequate knowledge and skill in the managing of the disease. So that is why we have to describe. What I do is, we will explain to the patient what is the condition once we take up the history, and then we'll also brief them about the course of the illness. If they know about this, they will definitely adhere. And low attendance at follow-ups. They will not come to the follow-up regularly. They will have medication directly from the pharmacy. Physical difficulties like some illnesses or some physical disabilities may be there. Substance abuse and dependence. These are very poor adherent people for the therapy, because they want to continue medication only when they are abstaining. And once they start drinking, they are having drugs, they will stop this. This is how adherence is very poor in them. And forgetfulness and anxiety, of course, they are the another factor. So this is the doctor-patient relationship. You can see all these things. Doctor and patient. Doctor should have a shared belief, compassion to the patient, being present in the sense. I have seen some doctors taking history and talking on the phone somebody else. Mutual respect. We have to respect the patient and attendance, and knowledge and experience they should have, and they should explain in their language what is the condition they have come for. Confidentiality is very important. Personal chemistry is very important, because our attitude towards the patient is also very important. Honesty and integrity, trust and confidentiality, all these are the important factors of doctor-patient relationship. The better the relationship, much better will be adherence. So there are some reasons for these non-adherence. Some say they are very costly, we could not afford, and some say that they could not remember that they should take medication, or they should refill it because of some work or whatever it is, or whatever their next priorities. Some of them are concerned, not some of them, most of them are on dependency. Because now even I've seen people talking about all psychiatrists they give is all dependency drugs, they should not be taken for a long time. For this, we need to spend more time with the patient and explain them what is the problem, and dependency, what it is dependency, and why we are not giving such drugs. And drugs we prescribe are not dependent every time. So they are skeptical about the benefits also, whether I will get cured about it or get only sleep. Even non-psychiatric people, they say they give only sleeping pills. So because of this in mind, they have skeptical ideas about the benefits of the problem. And challenges adjusting my routines. Suppose we advise for the this thing for during de-addiction, we ask them to avoid jobs where in bar etc. But the thing is, they are very difficult to have adjustment to their routines because of the livelihood. So some people may say afternoon drug we cannot take because I was out of home, like this. So these things are there. Issues with availability. Sometimes many patients in our rural areas, interior part of the Karnataka, they never take, most of them will not take whole month prescription. They will take only 10 days medicine, 5 days medicine, like that. When they come back, it may be late also, and same batch may not be available, and that is what amounts to issues with non-availability. Perceived social stigma, it is not there actually. Almost hardly 10% I see here, especially in the highly educated people. Rural and uneducated have no stigma at all. Some people may say, I was not following because I didn't understand your instructions. So, some say they don't deviate. So, these are the reasons. And condition related factors are severity of the symptoms. More severe the symptoms, they forget to take. Level of disability like physical and psychological and social and vocational. Rate of progression and severity of the illness. The more the progression is the disease, severity of the illness, they will tend to forget and they will roam around to different doctors. Availability of the effective treatment is very important because sometimes what we prescribe may not be available in the area. So comorbidity is another factor related to condition factor, that is disease factor. If there are more than one comorbid conditions, they will have to take all medications together, and that makes them sometimes non-adherent to psychiatry medications. So healthcare system, in this factor, we have so many things like lack of accessibility, long waiting period as you see in the picture. Long lack of accessibility is because, suppose I will tell you, from Bombay, I have around 10 to 15 patients coming once in 3 months because they are not accessible to the psychiatrist in Bombay. And they will come to only once in 3 months for follow-up, and we will give them 3 months medication because they are from the Raichur itself, Raichur and around. So this whole lack of accessibility makes them poor adherent. Long waiting time because they have other priorities, they will just can't have patience to wait. That something has to be done for that. Difficulty in getting prescription filled because they may not be available in the stores. Unhappy clinical visits because of long waiting period and short consultation. They will have to come all along for a few kilometers. They have to wait for hours and they will have hardly 5 minutes consultation. So that makes them unhappy and they may stop. Good doctor-patient relations, as I said, have a good improvement in the adherence. Communication style of a doctor and interpersonal style of doctors are more important than socio-demographic factors, as I observed here. See, many of the time, interpersonal style of doctors, that is, they have to communicate to the patients in their own language, in their own level, and make them understand. Then only they will be able to follow and adhere to the treatment. Inadequate and non-existent reimbursement, this is not much so in our area. Poor medication distribution system, especially in the public sector like government hospitals, because every time they may not be available. Inability to establish family and community support, and self-management capacity will be less. And some people, they say, I didn't know that I had to continue for so long. This is about health related. So disease related. This is about socio-economic factors. So in our areas, especially in the interior part of the Karnataka, poverty is the main, poverty and illiteracy. Poor socio-economic status is the main cause for the poor adherence. poverty has to be addressed by the different sector. Low level of education and illiteracy is another reason for the non-adherence or poor adherence. But what I see is low level of education, people are yielding to the suggestions, but highly educated, sometimes they will not. Unemployment is another thing because they have to afford medication. Lack of effective social support network may be there. Unstable living conditions and frequent transfers and all. Long distance from treatment center and high cost of transport. So this is another thing we have to address during the for improving. That will be taken up by the next speaker, our friend Anand Pandurangi, next time. High cost of medication is another factor. Nowadays, traditional drugs are better than newly novel antipsychotics or whatever it is. But what it has become a fashion that we have to go for the modern drugs, like latest version of the drugs. But I am actually satisfied with the patients that old traditional drugs, so both antipsychotic as well as antidepressants, they are more effective and better affordable to the patients. Family dysfunction is another. Any problem in the family may have adherence thing. Therapy related. See, many of the time, I have seen some prescriptions, complexity of the medical regimen. So more than few drugs. Suppose if patient comes with depression, we'll add 3-4 drugs. If it is psychotic, we'll have 2-3 drugs along with that other additives. And if they are diabetic, they have to take those medicines from the other doctor. So this is complexity of the medication makes them poorly adherent. And duration of the treatment period, of course. Previous treatment failure. This is another important factor which is related to therapy. So if they have poor results from the previous treatment, from same doctor or other doctor, immaterial, they will have poor adherence. Frequent changes in the treatment again makes patients to have poor adherence because every time we change the medication, it will have their own drawbacks because of delay in the effective therapeutic stage. Immediacy of the beneficial effect. Many patients, they want improvement in short time. So because we have long-term window period is there, unless we explain them, they will have poor adherence because of no immediate effect. Medication side effects, of course. This after diagnosis, I will come to my experience. This is very important because we have to explain them possible, probable side effects and the treatment. Route of administration is also there. Degree of behavioral changes is required. Suppose if you ask them to stop both alcohol and smoking and gutka at a time, it is very difficult and they will try to escape from the doctor. So how do we measure? Direct methods like direct observation therapy, what we call, we implement we had implemented in this method in RNTCP program, revised National Tuberculosis Control Program. Like that only, I insist the attendants to go for this dot. Measurement and of the drug serum level, and these are all very not affordable in our area. Patient self-reporting, it can be done. Pill counts and pharmacy fill data, these all can be measured. Electronic medication monitoring, assessment of patient's clinical response also very important. So what I do to improve adherence by patients? After provisional diagnosis, after history and all, I brief the attendants and patients regarding their condition, that it is a chronic disorder. It is like diabetes or whatever hypertension, you will have to maintain it. There is no cure for it. We have to tell them frankly and make them understand that yes, and it is not a disease which can be cured in limited or a limited period. Most of them, whoever comes here, they will agree for that and they will obey. Course, I will also explain them about the course of the treatment, acute and maintenance phase, slowness of the drug effect, and need for long-term maintenance medication to avoid relapse. And I advise attendance for uninterrupted supervised medication by a responsible person in the family and regular follow-up to facilitate counseling and symptom reduction. This is what I counsel. And usually I never advise patients to self-medicate, but I will advise them to follow the instructions of a responsible supervising member whom we have entrusted, and probable side effect of the prescribed medicines, and not to get worried or misapprehended, but to report back. So we have to explain them these are the side effects which may occur, and you need not worry about that. We should assure them that there is a treatment for that, and we have already added. Even if there is some problem, you can come back and give feedback so that we can rectify that. That we need to tell them. And I do tell them, brief them about the side effects. And I make a brief note on the prescription sheet so that it will be helpful for follow. So I verify all my instructions regarding adherence during subsequent follow-ups, and counseling will be continued. So these are some of the pictures of the cell dot, direct observed treatment. So my experience is, in spite of all our effort, adherence is still, it is hardly 50% once the patient becomes asymptomatic. Very poor among substance dependence syndromes and major mental disorders, including MDD. And age, education, and social status made no difference in adherence because both sides are there. But poverty and affordability makes difference, definitely, and adherence will be poor. Rural clients are better than urban clients in terms of adherence. Attendance to follow-up is very poor once they become asymptomatic, and relapse rates are fairly high, but most of the patients refill their prescription directly from the pharmacy whenever they feel uncomfortable without medication, especially patients with substance abuse. They will come back. They turn up to the consultation if refill is refused by the pharmacy, or if they have any new symptoms they notice. So DOT is the best way to improve the adherence. That's what is my experience, and I advise and I follow it. And thank you one and all for your patience sharing. Be safe and stay healthy. Thank you.
Thank you, Dr. Mali Patil, sir, for the extensive presentation on adherence and the factors affecting it, patient-related factors, and doctor-patient relationship, and concerns about the cost and forgetfulness. And sir has also shared his experiences about improving the adherence and stressed on DOT therapy and hurdles of the adherence. Thank you very much. And I would like to request all the participants to post the questions in the question answer session. We will discuss after the second speaker completes his session. Now I would like to invite Dr. Anand Pandurangi sir for the session on improving adherence. Over to you, sir. Pandurangi sir. Hello. Hello.
Yes, sir.
Hello.
Yes, sir. You're audible.
Pandurangi sir.
Dr. Pandurangi, sir. Fantastic.
Yes.
Sir, you need to unmute and speak, sir. Pandurangi, sir.
He's unmuted only. I think some audio is not coming.
We can't hear you, Pandrangi sir.
Sir, ಕೇಳ್ತಾ ಇದೆಯಾ sir? Pandrangi sir?
We cannot hear Dr. Pandrangi yet.
I will call him. Sir.
No, I think sir could be hearing us. If there's any issue, he has to log out and log in again.
Mahesh,
Yeah?
who? You next speaker?
Hello.
Sir, Dr. Pandrangi.
Hello. ಇದು ಅಂಕಲ್ ಅವ್ರ ವಾಯ್ಸ್ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ. ಅಲ್ಲೇ ಇದ್ದೀನಿ ಅವ್ರ ವಾಯ್ಸ್ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ. ಅದು ಸ್ಲೈಡ್ ಶೇರ್ ಆಯ್ತು. ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಬೇಕಾಗ್ತದೆ.
Hello, can you hear me now?
Yes, we can hear you now.
Yes.
Can you hear me now?
Yeah, we can hear you.
Yes, sir. We are seeing the star speaker now.
Yeah,
sir.
not star speaker, man. Good evening, everybody.
Good evening, sir.
Good evening, very good evening to every one of you. A very good initiative by Indian Psychiatric Society, Tele Arogya. My compliments to Dr. Mahesh Goda, Dr. A. Jagdish, and Dr. Vijay Harbishettar. My co-speaker, Dr. Malik Patil, Dr. Narayan, Ganeshan. Compliments to all of you for a wonderful program that you organized. I heard Dr. Malik Patil, a senior colleague of mine, and he has exhaustively covered. I was very happy when he mentioned about communication skills, doctor-patient relationships, and all that. And having been in the field of psychiatry, especially community psychiatry, for the last 35 years, I personally feel practicing psychiatry at the community level, psychiatry is 50% science.
Dr. Pandrangi, sir, can you come closer to the mic, sir? It would be nice if you're more audible. Closer to the mic.
Yeah. Can you hear me now?
Yes, sir. Better, sir.
Yeah, better. Okay.
Yes, sir.
So having been in the field of psychiatry, community psychiatry for the last 35 years, I feel practicing psychiatry is 50% science and 50% art. And 50% art makes all the difference in improving the adherence of patients to the therapy. So slide. Yeah. So adherence to treatment of psychotropic medication remains poor overall despite the availability of effective medications. See, we have newer molecules, atypical antipsychotics, and so many other new molecules even in management of depression. See, with all the newer molecules operating at different levels of mechanisms also, but still many times we feel quite difficult to see the adherence of the patients to the therapy. So many factors have been implicated for poor adherence to the treatment, maybe because of poor insight about the illness also, about the medication also, and the negative attitude. As Dr. Mali Patil was mentioning, most of them think visiting a psychiatrist, they use sleeping tablets. That type of idea is there in most of the patients also. Negative attitude or subjective response towards the medication. Individual subjective response to the medication also is different. Previous non-adherence, substance abuse, shorter illness duration, poorer therapeutic alliance, and I think it makes a lot of difference when we think of it. Maybe because we all know that most of these psychological illnesses are known to recur and relapse. When we know that the recurrence and relapses are very common, I think we need to have good communication skills good doctor-patient relationship to improve the adherence to the therapy. Next slide. There are some other factors also, like regional and ethnic variations may exist in adherence to the treatment with psychotropic medication. Some of the cultures may not accept the therapy also. Some of them may not accept the treatment also. Medication adherence and methods to improve it is thus pragmatically ingrained within the context of service provision. WHO says about 50% of the patients with chronic diseases do not take their medications as prescribed, which you all see in our day-to-day practice also. And 41.2% to 49.5% of the persons with schizophrenia are non-adherent to their prescribed treatment, which we all see in our practice day in and day out. Next one. Though the terms adherence and compliance are synonymously used, I feel adherence differs from compliance because compliance implies I say you listen to me. Patients should be more obedient to the physicians. It gives an impression that the physician is ultimate and listen to what I say. So adherence signifies that the patients and physicians are collaborating to improve the patient's health by integrating the physician's medical opinion and the patient's lifestyle also. It is respecting the patient's sentiments and values also. It is a coexistence between doctor and patient. This is what we generally see. It's more value relationship. Next one. So methods to improve adherence, the effectiveness of treatment depends on both the efficacy of medication and the patient adherence to the therapeutic regimen. And at this time, I want to tell what Dr. Mali Patil mentioned about. He's quite comfortable with the old conventional antipsychotics and antidepressants. We both of us sail in the same boat. We are blend of older molecules and newer molecules also. And I also certainly feel that most of the patients are very comfortable. Not that they are not happy and comfortable with the newer antipsychotics and newer antidepressants, but certainly when we look to the cost benefit of the patients, I think older conventional antipsychotics and these tricyclic antidepressants still hold good in our profession. So this is what he mentioned. I'm very happy about that. Patients' health care providers, that is healthcare givers, and healthcare system all have a role to improve medication and adherence. So everybody has to play their role in an effective way so that the patients ultimately don't end up in relapse to us. A single method cannot improve the medication and adherence. It's a multifactorial. This is what we generally say. Instead, a combination of various adherence techniques should be implemented to improve patients' adherence to their prescribed treatment. Because many times, as Dr. Mali Patil was mentioning, we write for a month, they take for a week, and they spread it over a period of 1 month. And older patients are so smart. When you prescribe one tablet in the night, they say, I'm comfortable with half tablet. Some of them, they make it 1/4 and say, I'm happy with 1/4 tablet. This is what we generally see in community practice. May not be seen in the institutional practice, but certainly Mali Patil agrees with me that most of them come, sir, you have prescribed one tablet, I take only half tablet, I am comfortable and I am asymptomatic. See, this is various multiple permutation and combination. See, instead, a combination of various adherence techniques should be implemented to improve patients' adherence to their prescribed treatment. Next one. So, when we think of a collaborative approach with the patient at the level of prescribing whenever possible, involve patient's decision making, because many times, see, it is the patient's comfort that we'll have to see. Many times I have seen we prescribe something, the patient says, I'm not feeling comfortable with this medication, can you change it? We say it is one of the wonderful molecules, please continue to take that. See, sometimes we need to listen to what the patient says, because Ultimately, we work for the comfort of the patient. And when I say it is the comfort of the patient, we'll have to respect the opinion of the patient also, because that's why we say involve patient decision making also regarding their medication, so that they have a sense of ownership and they are partners in the treatment plan, because ultimately he is going to take the treatment. If you don't regard him, if you don't respect him, if you don't listen to what he says, I think it doesn't work. That's why we generally say, listen to patient. A good psychiatrist, so that's why I said 50% art. When I say 50% art, you should be a good listener also. So simplify the medication taking also. Many times we see quite a lot of prescriptions wherein 5 to 6 or 7 to 8 items are prescribed, and see, given a choice to me, and if the same prescription is given to me, I find it difficult to take. What is morning, what is afternoon, what is night, we find it so difficult. So I think prescription has to be made so simple that it should be patient friendly. I always say that any prescription that we give should be patient friendly. Next one, now. Next one, next one. So it should be a patient friendly prescription. This is what we generally see in our. So communicating with the patient and caregivers, psychoeducation about illness and the prescription options. See, we need to explain them about biopsychosocial model to them. See, as Dr. Mali Patil was mentioning, I was very happy when he said, it is just like diabetes and hypertension. See, can you cure diabetes and hypertension? No. It is a treatable illness. In the same way, we will have to educate our patients that it is like diabetes and hypertension. You need to take patient. You need to take these medicines for a long time, maybe a lifetime also. If you tell them it is a lifetime medication, I think they accept it. It is like any other illness. See, this is what we need to educate them. Sometimes we say take for 3 months, and then they think they are fine and they discontinue again, they end up in a relapse. Rather than that, we must educate them saying that maybe a depression, maybe a schizophrenia, maybe a bipolar disorder. These illnesses are known to recur and relapse. When you say that 2 hours, I'm sure the patient will be mentally prepared to take it. So inform the common side effects of the patient, common side effects of these medicines, and those that patient should necessarily know. Sometimes we prescribe medicines and they present with extrapyramidal symptoms or some other dryness of the mouth, constipation, when you prescribe conventional antidepressants and all that. And even when we use SSRIs like escitalopram and all that, they may present with severe gastritis. So all these things have to be explained to them because they are mentally prepared for that. And doctors should be accessible. I was very happy when Dr. Mali Patil mentioned that accessibility is more important because he gets patients from Bombay and once in 3 months they come to him. The most important thing is accessibility of a consultant and accessibility of a doctor is very important. Many times when I say patients are available 24/7, even on my mobile, they will be surprised. And many times patients have tested me giving a ring at 2 o'clock in the midnight. And second ring, I pick it up and they say, I salute to you. Why they say that? Because you are accessible to them and you are approachable to them. This is what is required when you are committed to the profession. And patients would be more worried and lead to non-adherence due to the side effects that was not cautioned to them. See, that's what I said. Common side effects must be explained to them. We use parenteral antipsychotics, and second or third day they present with dystonia and some other things. And if you explain them, you are likely to get this, and don't be worried, don't be scared, don't be nervous. Please call on us. I think they are mentally prepared for that. So this is what is required by our healthcare professionals. Next. Identify the difficulties and barriers related to the adherence. Doctor-patient relationship, Mali Patil has explained in an exhaustive way. Patient, pharmacist, communication central to optimizing the patient adherence. See, doctor-patient relationship makes all the difference. Good PRO can solve most of the problems, because I've seen many times doctor facing some kind of allegations by the patients and getting some legal notices from some of the patients. I always say if you have a sweet tongue, I think you can get over everything. So good patient-doctor relationship can solve most of the problem. That's what is my personal experience also. Patient and family involvement in decision making is essential because many times when patients are psychotic or when the patients are uncooperative, it is the family members will have to see that the medication is administered and adherence to the treatment is managed by them. So involving the family in decision making is the most essential in improving the medication adherence. So use of medication adherence improving, it's like providing medication calendars. Dr. Mali Patel also mentioned about that specify the time of medication, medicine related information sheets, special small containers, maybe day 1, day 2, day 3, day 4 like that, or Monday, Tuesday, Wednesday like that. Special containers you do get in the market, and indicating them the time and dosage, I think makes a comparatively more adherence to the patient. Provide behavioral support. Essential is that in those on complex drug regimens, like if they are diabetics, hypertensive, if they are COPD patients, there are so many other things which have to be considered, and adherence, especially in elderly patients, if they are dements, if they are Alzheimer's, I think you need to educate the caregivers regarding the medications and make them more adherent to the therapy that is being explained or given to the patients. So schedule appropriate follow-ups, maybe initially once in 15 days or once a month. Monitoring the medication adherence should also be a creative while scheduling the patient follow-up. Measure adherence by various methods which may be dependent on patient as well as drug characteristics. This should be done by us as well as by the pharmacist also, because see, it's a teamwork. It is not that I prescribe and patient take it home, and it is the involvement of the pharmacist, involvement of the doctor, involvement of the psychologist, involvement of the counselor, involvement of the family members, and involvement of the community also. I go one step ahead and say involvement of the community. Sometimes you see the wandering lunatics. They need help. They need to be guided. So this is how it's a teamwork. Psychiatry basically, I think it's a teamwork. We all need to join our hands to see that the adherence to the patient is given in a proper way. So complexity of drug regimen is found to negatively affect the medication adherence. See, if we prescribe 3-4 combinations, I think patient may not accept it. That's why I said, and I reiterate that whatever we prescribe has to be patient friendly. Patients should be comfortable in taking that. They should feel that it is easy to take, because one morning, one night, or only one in the night. I think that makes all the difference in adherence to the treatment modalities. So this method often calls for patients' cooperation, thus highlights patients' participation and also in the disease management. So methods to measure the adherence, which is being told by Dr. Mali Patel, the same thing I want to brief it just. Direct methods include direct observed therapy measurements like levels of the drug, maybe blood tests. When we keep them on lithium as a mood stabilizer, I think we need to monitor lithium levels and all that, and metabolites in urine and blood. Direct approaches are one of the most curative methods of measuring adherence, but are expensive also. That's what my colleague Mali Patel also explained. Moreover, variations in the metabolism and white coat adherence can give a false impression of adherence. This is what we generally see in our routine. This one. Indirect methods include patient questionnaires, patient self-reports, and pill counts, rates of prescription refills. Because many times we prescribe a tablet, they see us after 1 or 2 years because the pharmacist is not giving them a refill or honoring the prescription. assessment of patient's clinical response also is most important because um, many times we see residual symptoms in the patients, which is very common. I think regular follow-up has to be instructed to the patient and to the relatives also. Each method has its own advantages and disadvantages, and no method is considered as a gold standard because that's why I generally say most of the things what we speak is easier said than done. The simplest way of measuring the adherence is from the patient's self-report. When he comes, when you examine him, and if you feel he is asymptomatic, definitely he is adhering to the prescription or treatment what you have given. So assessing children's adherence can be done by asking the help of caregivers because sometimes we see ADHD children or some behavior problem in children or borderline personality issues and all that and such things. I think managing that has to be done by we need to have evaluation report at the school, at the family level, and I think it is a parent's responsibility to see that the treatment adherence is done. Questioning the patient can be susceptible to misrepresentation and tends to result in healthcare providers overestimating the patient's adherence. Sometimes they say, I'm absolutely all right, but they may not be taking the treatment also. See, this is what we generally say. Uh, he must have remission, but we should also know that he is bound to get a recurrence and relapse. So pill count is a common method to measure the adherence. Though this method is simple, it has many disadvantages that the patients can switch medicines between the bottles and may even discard pills before hospital visits because many times we see psychotics, relatives just put the tablet in the mouth, he keeps it under the tongue and he spits it out. This is what we generally see, and even in institutions we used to put it in his mouth and see that he swallows that. This is what we generally see. Discard the pills before the hospital visits in order to appear to be following the regimen. Rates of refilling prescriptions are an accurate measure of overall adherence in a closed pharmacy system where health maintenance organization continues with universal drug coverage since refills are measured at several points in that time. So this is how we need to observe at different levels. So thank you very much, and it's a wonderful thing being with all my colleagues. Due to COVID, I'm very happy that academic has not stopped and academic programs are continuing despite COVID lockdown and because physical conferences, physical seminars, physical programs are not possible. And I'm very happy. My thanks to Dr. A. Jagadish, Mahesh Goda, and especially Vijay Harbishatar. He was so much in constant touch with all of us. So thank you, Dr. Vijay, for your aggressive involvement in this program. Thanks to every one of you. Thanks to Micro for the good. Ganesh, thank you very much for being with us and being a part of the program and sponsoring this. And thanks to every one of them. Narayan, you did a wonderful moderation. Thank you very much. A good introduction by you. Thanks to that. Thank you.
Thank you.
Basically, I am a community man.
Thank you, Dr. Pandurangi sir, for
I think sir
thank
has
you
to
very
stop
much,
sharing
Dr.
the screen.
Pandurangi sir, for your
Dr. Pandurangi sir has to stop sharing the screen.
Stop sharing the screen here. Yeah, I'll do that. I'll do that once.
Yes. Yes, thank you. Thank you very much, Dr. Pandurangi sir, for
Yeah, no, thanks.
excellent.
both of us are seniors, Mali Patil and myself. Mali Patil is senior to me, and both of us are into community practice. And our experiences are same.
We basically
And
are
I would
not
also like to. Hello.
Yeah, please go ahead.
Narayan, carry on.
Carry on.
Vijay.
Thank you, very much, Dr. Pandrangi sir, for sharing your secret of practicing psychiatry as a combination of science and art.
Yes,
You
sir,
have
thank you
shared
very
your
much.
secret of successful psychiatry.
No, because
Thank
it's
you.
an art.
And
It's
you,
an art.
sir has
Practicing psychiatry,
enlightened.
I feel it's an art. Psychiatry is an art. Basically, it's an art.
Yes,
Practicing
yes,
psychiatry, you need to be more presentable, and it's an art.
yes.
And you
Thank
need
you.
to have a good
And
PRO, good
we will
PRO.
go to the question.
Yes, sir, sure, please.
Okay, sir. We have one question from Dr. Jwala. It is for both the speakers. Will psychotherapy, like insight-oriented psychotherapy, improve drug compliance? I will read it once again. Will psychotherapy, like insight-oriented psychotherapy, improve drug compliance?
Yeah, I think it does help to some extent, because psychotherapy, when you do it, especially if a patient is psychotic, if a patient is uncooperative, non-cooperative patient, I think any amount of your psychotherapy many times may not work. So I think it's worth trying. There's nothing wrong in trying that. There's nothing wrong in trying that. Psychotherapy do help, but that depends on, nothing is tailor-made. My colleague should know that. No drug is tailor-made, and no treatment modality is tailor-made. This is my personal opinion, because what suits you may not suit other patients. So in that case, I think it's worth trying. There's nothing wrong in that. There's nothing wrong.
Yes. Thank you very much, sir. To brief again about that. My sir.
Dr.
Hello?
Bijal may want to ask something.
Yeah, please.
Okay.
Hello, teacher.
Yeah, good evening to all. So we are very lucky that we have listened to the two Diggajas of Karnataka and Tripura Karnataka. We're happy that.
What Somo?
And as Narayan sir has told, we're lucky to know the secrets behind the success. Okay. I just like to make one comment, sir. It's not in a question or anything. So myself and Dr. Mali Patil sir, I think in way back in 1997, we started our RNTCP training together in Raichur when Dr. Reddy was there as a DTO. In the last 30 years, our experience with respect to the tuberculosis program is, so today we have come to the stage of Nikshay. By 2030, there will not be any TB cases all over India. So why can't we think in that area? Of course, I request Narayan, Arbi Setter, and many of the people, why can't you start DOPS, something like the DOPS, directly observed psychiatric schedule, whatever it may be, DOPS or something, DOPS, something you can name. And we can start pilot. I think Narayan and myself, Vijay Harbishatter.
Vijay is more active.
Yeah, we should think in that direction. Take a pilot project. We can prove that DOPS definitely will help. Definitely there will be PAN-SS score will be less. There will be more improvement rates and all. If that can be practiced in over a period of time. Of course, it may not be possible to reach the stage of Nikshay, but at least the mental health gap can be reduced, and early recovery, and we can reduce the disability related to the mental illness. That's what I feel, sir. Thank you, Mali Patil sir and Anand Pandrangi sir.
I fully agree with you, because what Somo said, I think if you can educate community, if you can educate people about common psychological problems like depression, which is the most common, complex, chronic, crippling, and disabling. When you say disabling, they stick to the treatment. When you say that depression leads to disability, they definitely accept the treatment. See, most of the time when you see a case of major depressive disorder, you know that about 70-75% of the patients will have relapse after discontinuing, maybe after 1 or 2 years. And who knows if that relapse is with a suicidal attempt or a successful suicide, you don't know. So if you can educate them that it is like any other illness, I think most of the patients do stick to that. I do have quite a huge number of patients who had suicidal attempts and they are on antidepressant for the last 15-20 years. 15-20
Somsekhar,
years.
hello.
Mali Patil agrees with me for that.
Yeah, my success story is dot only. I
Yeah,
never
yes.
asked any patient to take medication. That's why my last sentence of the last slide was dot is the only principle.
Yes, yes, very true.
So principally I practice that only, and my patients attendants, they are really very much happy because they are able to get good results because of their support.
Ultimately, they should go happy.
That
See
is the only
what Mali,
way,
yeah.
because in our area at least 50% of the people are very illiterate, and even educated also, they tend to forget and tend to have their own priorities and try to be non poor adherent. Dot is the only best way to keep adherence and improve the conditions.
Ali
That's why
Patil, I 100% agree with you that it is the illiterate and uneducated people who are more adherent to treatment modalities than educated people.
definitely.
No, in fact, as you rightly said, when they go happily, see, you may not spend more time with them, but the very presence of you and your accessibility is good enough for them many times.
And during follow-up also, we will be assured that they are adherent, because
Adherent.
the attendants, responsible attendants to whom we had entrusted, they will come to the clinic and tell the story about it. And we have to believe them.
Yeah. In terms of depot preparations, is it a failure of psychiatrists to convince the patient, or is it
No,
you
I
need a
think,
set of patients that have to be given depot preparation?
I
no,
don't
I
think
think
it is a failure, but in very violent cases, I do practice with the depot preparations. Today itself, I had 2 patients admitted, and I have given depot preparations. That is very essential to combat the acute symptoms.
No,
Okay.
I fully endorse what Dr. Mali Patil said. If a patient is uncooperative psychotic, I think it is the only depot preparations which are worth trying, because even if he skips antiparkin drug, he ends up with some extrapyramidal symptoms and finally he comes to the doctor. So you can make it more adherent also, because depot preparations are really good when the patient is uncooperative and non-compliant or non-adherent to the treatment modalities. I think depot preparations are, I fully agree with Dr. Mali Patil. We still use quite a huge number of patients with parenteral antipsychotics, depot preparations.
And $1 million question: how do you enhance doctor-patient therapeutic relationship?
I think you need to be cut out to be a, your personality has to be tuned for that. See, you can't, see, it is basically your personality, is it not? See, doctor-patient relationship have to be improved. If a person is to himself, if a person is not having good communication skills, I think you can tune and train him, but basically you should be cut out to be a psychiatrist, is it not? With all good communication skills and all that. What patient needs is your convincing, not how much you have read or how much you know or how many papers you have published, is it not? What patients want is relief, not my research or not my degree, is it not? Ultimately, what he wants is he wants to be happy and he wants the result. Dr. Mali Patil agrees with me, is it not? Ultimately, he has to be happy with the treatment what you give.
Once the patient enters the consultation room, they will go back only with happy note.
Yes,
Until then, I will not leave them. At least I will greet them.
They should smile and go.
Yeah, definitely. I never bother how many people are waiting outside because we have TV and other papers and other things. But we have to satisfy the patient so that attendance will be very
Yes.
quick.
Now you know the secret of Dr. Malik Patil.
Yes, sir.
The good communication skill, doctor-patient relationships. And you see, every consultant has the same.
More time we spend with the patient and the attendants, we have to convince both attendants as well as patients. In some
See, if you see, Malik Patil, you agree with me, if a patient is schizophrenic and hallucinating, you need not have to spend time with him, spend time with the relatives.
we have to spend time with the attendants.
Relatives,
It's very
relatives,
important
attendants,
because they are
attendants.
the one who are dot people.
And many times you agree with me, they leave the patient and say, sir, you just ask him what is there in his mind. But that fellow is hallucinating. They want to leave him and go outside. So I tell them, Arey Baba, you please be with him. I know what has happened to him. This is what we say, isn't it?
Yeah,
See, by look.
Major mental disorders, we cannot convince the patients,
Yes,
but we have to convince
relatives and attendants.
Need for the long-term treatment, need for the supervised medication, not in the not.
See, I call you as a good clinical psychiatrist. The moment he enters your consulting room, you should be able to diagnose.
Yeah, of course.
Before taking history by face, by looking at his face, you should be able to diagnose for what he has come. I think if you are able to do that, I think you can clear up any huge crowd that you have in your hospital.
Our examination starts once we see the face in the door of the chamber.
Yes, at the entrance.
Entrance.
By look of the patient, you should be able to, is a psychotic, is a depressive, or
most important is rather than patient, we have to convince the attendants because they are the one who are frustrated.
See, attendants have to be convinced. Especially, I said no. Patient is hallucinating. How can you spend time with him? You have to talk to the relatives and explain them what is the illness.
You have to explain in their own language.
Yes, in their own language,
level,
in their own understandable way.
That is important.
And many times they ask us, we went to some spiritual, religious, traditional healer and all that. I never say anything to them. Continue that also, but never stop my treatment. This is what I generally say. You want to wear a thread, you wear it. You want to wear a taviz, you do it. You do anything you want, but don't stop the treatment.
And during this Ramadan month, would you change the treatment or?
No, I think if it's a psychotic, I insist them. See, any religion or anything that you say, if a patient is on treatment, I clearly tell them.
So when they're doing Rosa.
No, even during Rosa time, I tell my patients, see, if you want to be fasting, see that the medication is given immediately after Azan in the morning, after they have their food, and in the night. See that is taken without fail. You may fast the whole day, but see that the medication is given. No stopping, especially if it's a psychotic, don't stop. And if it's an epileptic patient, mental retardation with epilepsy, subnormality with epilepsy, or behavior problem, psychotic presentation, I think they need to take medicines, and you will have to tell the relatives. See that the medication is given. Even if they are on Rosa, I tell them it is a must. It is mandatory to take the medicine. Never ever stop the medicines. You have to be very clear to and no person, no patient has to be fasting. He has to take it. He has to take tablets, whatever it is. You'll have to explain them and they accept it. They accept it. And that all depends on the way you convince, the way you explain them. I think none of my patients said, we want to continue that. They say that you are a patient, don't do it. They accept it. Ultimately,
accept.
The amount of confidence you create in them is more important.
Yeah, of course. And we can change the timings also because at 4:30, 5 o'clock they will have food, and again at 6 o'clock.
Immediately after Azan, you can tell them.
Just the time.
And we have in Bangalore, we have another issue of this night duty staff and changing shifts. There again, we have to adjust according to their their duty timings.
Time, and if you are giving in the night time, and if he's going for duty in the night, I tell them you come in the morning, have your food or breakfast, take the tablet and sleep. This is what we do, but never ever miss the day dose. Daily dose should not be missed. It has to be taken.
But
So
try to
another,
avoid that. In such cases, we'll have to avoid sedatives during night if they are on night duty. But we have to shift the
The daytime.
morning to night like circadian rhythm. So
That's
we have
why I
to
say, Dr. Malik, is in art. Psychiatry is 50% science and 50% art. You need to use your common sense. That's it.
sir, what about when they ask, is it okay to have one peg or one bottle
No,
of
no,
beer?
no. I don't.
It's a very common question they ask.
Common question
very
they ask.
difficult question to answer.
Difficult to say. I just give a pat and send them. I don't answer them. I just pat them and send. That's it.
And
Sometimes
if we say that they should
I
not,
just
we will have it. And we'll have to
put my
keep
hand
silent
on their shoulder and
as
send
long
them.
as they are adherent to the medicine.
I tell them you are a very smart patient, go. That's it. I neither say take it nor say no. Smart patient, go out.
Okay. Dr. Mutalik?
Yeah, very nice.
Yes,
Vijay.
sir.
It's quite interesting to meet all of you and have a nice.
So I think we don't have any more questions. So
Dr. Rangnath wants to ask anything. Dr. Rangnath Kulkarni and Dr. Raghavendra are there. They can unmute and ask anything, comment on anything. Okay, Dr. Mutalik.
Yeah, nice,
Yes,
Vijay.
sir.
You did a wonderful job.
So we can, I think we can, if there are no questions, we can conclude the session. At the outset, I would like to thank all Telearagya team, Dr. Mahesh R. Gowda and Dr. Jagdish and Dr. Kumar Harbishettar, and for making this event successful. And both the speakers, Dr. Pandurangi sir and Dr. V.A. Mandi Patil sir, for giving their valuable experiences and for giving their valuable time for this session and enlightening us on adherence and how to improve adherence. And I would like to thank all the participants for actually participating in the session. And lastly, I would like to thank the micro team, Mr. Ganesh Ansi and all his team for making this session successful. So thank you one and all.
Thank you.
Yeah, thank you very much. And one more thing, this will be sitting in the YouTube, so anybody can watch anytime. And there will be, we'll be sharing again to a lot of people, and they'll also be able to watch this in future. You are also welcome to share to anybody, sir. There is a lot of learning, lot of tips given by both eminent senior clinicians.
Let's adhere to our chair.
Yes, sir. Thank you, sir. Thank you very much.
Sir. Special thanks.
Thank you.
Special
Thank you very
thanks
much.
to both of you. Special thanks to both of you, sir, for
No
having
thanks.
made.
Thank you, Ganesh.
Thanks to
They're
Dr.
part of the
Mutalik.
team. They're all members of Indian Psychiatric Society.
And
Right.
despite a busy
Pleasure.
clinical work,
Pleasure, Vijay. Pleasure.
Yes, sir. Thank you, sir. Thank you.
Thank you, sir.
Thank you very much.